Good evening, everybody. Welcome to our latest show and to Call the Doctor. And today we have a very special guest, as we really always do, but a very, very special guest today, Dr. Carone Warrensby, who just typifies the wonderful changes that we're making in the Nash system over the last several years. She is a general surgeon, new on staff, relatively new on staff.
1 year.
And why don't you tell us a little about yourself?
I am originally from Chicago, Illinois. Grew up there. I went to Tuskegee University for undergrad and University of Illinois at Peoria for medical school. And then I went to do my residency training for general surgery in Brooklyn, New York at Brookdale Hospital.
You're moving all over the place.
Yeah.
So did I.
Education will get you to travel.
Right.
And then after residency, I was in a practice for 16 years in Marshall, Michigan, the southwest part of the hand.
I lost your Brooklyn accent there, right?
Exactly, right. And practiced there for 16 years and then decided to transition here to North Carolina to UNC Nash Hospital.
That's good. Well,
Yeah.
welcome.
Thank
Welcome.
you.
Under the guidance of our amazing administration at
Yes.
Nash, I mean, we've really made a wonderful transition, literally in every single department of the
Absolutely,
hospital.
yes.
Would you agree with that?
I do, and
Yeah.
we leapfrog A. I mean, we are just the
Absolutely.
third time in a row, which
Yes.
is the top that you can be, and that's fabulous.
Right. There's literally not another hospital in the entire state that's rated higher than us. Is that a true statement?
Right.
Right.
I mean, and it's on our quality, on patient care, everything.
Absolutely.
Goes into that, and we're
It is,
A rating
and,
now.
So before I ask Dr. Warnsby to tell us, let me give an apology to everybody who's listening. I have laryngitis, and so to your, as a blessing to you, I may talk less, but my voice is going to change. And I'm not chewing gum. I'm actually have a supply of cough drops here, and so hopefully I won't have to make an exit to my stage left to cough. But if I disappear, it's because my cough drop stopped working.
But we ladies will keep it going,
we'll
won't
keep
we?
it going.
Yeah, we'll
Okay.
keep it going.
Yeah.
Okay. So during this transition that was orchestrated by Dr. Isley
Yes.
and his wonderful team,
Yes.
Please tell us and define for us specifically what changes happened since when you're part of that change.
Yes.
So give us a little historical perspective. Tell us where things are now
Okay.
and why things are better now.
Okay.
Because that's why I invited you here, because things are palpably and visibly better for our community.
Yes.
And she's a major part of that. And tell us about the personnel that has stayed to help and the personnel that we've added on,
Okay.
and the significance of that.
Okay. So right as I came to interview at UNC Nash, it was two practices at that time. It was Dr. Seaman's practice, and then Boyce Willis surgical practice, and then covering the hospital were the surgicalists who basically rotated only in the hospital. They took care of what emergencies they could in the hospital, and then a lot of patients were winding up being shipped to other hospitals when they weren't available.
So a surgicalist is somebody that just stays in the hospital. They don't have a private practice.
Exactly.
They're not really part of the community, are they?
No.
Right.
Usually they're surgeons from other areas who are coming to work for a specific amount of time.
And then they go.
And then they leave, yeah,
Right.
they go back home.
They don't know anything about this. They have no commitment to us.
Exactly.
And so if you get an emergency gallbladder taken care of by somebody, you're meeting somebody you've never known,
Right.
and probably someone you'll never see again.
Exactly. The follow-up would be with one of the other doctors, either Dr. Seaman or Dr. Harrison. And at that time, before her retirement, Dr. Nell Robinson would see patients. So what happened was they merged Dr. Seaman's practice and Boyce Willis surgery and eliminated the surgicalists, and then we recruited 3 new surgeons. So I was one of the first of the three new surgeons that were recruited. And then there's Dr. Veronica Zachary, who is a new surgeon here. She started also last year. And Dr. Reese Alkire, who also joined about August of last year. So
that's a total of 5.
Five surgeons, all who live in this community. who stay here, who will take care of you in the emergency room, in the hospital, and then see you in our office.
Whose carts you're going to run to in
Exactly.
Food Line and Harris Teeter, correct?
Or Sam's. Sam's, exactly.
Right. The point is that they're part of our community.
Absolutely.
And I think that's important.
Yes.
When you live and work in a small town,
Yes.
and you treat people like they are your family, which is
Yes.
my practice's motto.
Exactly.
And the feeling I get from every practice in the hospital.
Yes.
The benefit to the community is immeasurable.
Yes.
It's and part of what we talk about on every show here is the advantage of staying local,
Yes.
because there's eminent talent local. You don't have to drive. Well, we'll talk about this, but you really don't have to drive to places like UNC or Duke or Wake Med for state-of-the-art care, because it
Exactly.
truly is in your back door.
Yes.
It wasn't always.
Right.
There were a few departments that really delivered an A+ job, but really, I would say over the last 5 years, every department at the hospital is tuned up and perfect.
Yeah.
You know,
Urology, orthopedics,
Orthopedics.
surgery. I mean, they have really, and cancer. Golly,
Yeah,
we'll talk about
oncology.
cancer.
the Heart Center.
Yeah, the Heart Center.
So we'll talk more
Cardiology.
about that and how they interplay with different departments. Like
Yes.
you've heard us talk about how I work well with the Wound Care Center, which is
Yes.
marvelous, and other departments. But share with us a little bit some of the modern things that you and other people have used it before you, but how we're really taking off with the modern technology. For example, there's approaching, soon we'll be having 1 million surgeries a year done in this country robotically.
Yes.
In 2017, it was 15 or so percent. It's probably 20%. One out of
Exactly.
5 surgeries now is done with the assistance of a robot.
Exactly.
Right? And the advantage of that, which you'll teach us about, is largely smaller incisions, faster surgery, and lower complications.
Yes, and easier recovery.
Teach us this.
So we've, at UNC Nashville, we've always had a robot, but now, as of July, we have the most up-to-date robot, Vinci System. It's the XI robot, and it is a way of doing a laparoscopic surgery.
So Da Vinci is a company that makes
Yes,
it. Okay.
yes, that's the one of the top companies that make the robot.
Really, this is standard, I would think.
Yes, is the standard. And so when most people say robotic, they automatically say Da Vinci and use it interchangeably.
Right, like Kleenex is a tissue.
Exactly.
Everybody refers-
Exactly.
Yeah, they started it all pretty much.
Exactly.
And the point being that our best system around is right down the hall, and
Exactly.
you use it every week.
We use it every week. Urology, general surgery, and GYN surgery will use it also.
Right.
Yes, and so it's still laparoscopic, small incisions. The big difference is the ability of the instruments to rotate and manipulate, so it's more like our hand movements, and it's easier to get into tighter areas in your body and perform complex surgeries with these small incisions. Sometimes we have to extend some of the incisions in order to get your gallbladder, your colon, your prostate out of your body, but most of the incisions are less than 1 centimeter, and then the bigger incisions may be 3 or 4 centimeters, like 2.5 inches. So it makes your recovery so much better. Also, it's less blood loss. So a lot of people hear about the bloodless surgeries, and that is basically because we can see with such a great magnification the different parts of your body in the tiny little blood vessels, we can control your bleeding better.
Much more precisely as
Yes.
All right, I want to ask a quick question. So are all of the physicians now required to train to know, because this is new for some of them, I would think, and
Some of
what's
them
the
are new.
training like to learn how to do it?
The training, Da Vinci is the company is very good at making sure you're trained. They have classes even at ECU, where they have a lab there. You can go and train on different animals, how to do certain procedures. And then the robot itself has a simulator, kind of like airline pilot where you can practice doing the procedures and get down the manipulations and the used to doing the procedures. So you can keep practicing every day, and then doing the procedures are so much more easier.
Yeah. Keeping your skill set high is important.
Exactly.
Yeah. And
Yes.
that's mandatory, isn't it? To keep
Yes.
your skill set high.
Yes.
Right.
So basically, if you, let's say you haven't done a certain procedure, because like colon resections are not as common, but they're common. But if you haven't done one in a couple of months, you can go and tune up your skills and say, okay, I'm going to make sure I have all the steps down before you go into your next case. Yes.
Right. I think we all, particularly in our youth, run through surgeries the night before, the day before. I dream about them the night
Yes,
before
yes.
before I take out a tumor.
Yes.
It just consumes us, and to have a procedure with a specific methodology
Yes,
that is designed to lower our complication rate
absolutely.
and helps us develop protocols.
Exactly.
I think that really enhances the state of the art of medicine and
Yes.
allows us in more rural communities to really meet that standard of care
Yes.
and exceed it.
Yes,
Right.
and so we can offer you the same thing that Duke or UNC Rex or UNC Chapel Hill offer right here at home. Bam.
With the exception that your neighbor's taking care of you.
Yes.
Yeah, highly
exactly.
skilled and trained
And your
neighbors.
family can be with you close in the hospital.
And you don't have to leave.
Yes,
Right. And you get the support systems that we need. When you get somebody ready for surgery, you still need a cardiologist to see
Yes.
them, perhaps if they're ill,
yes,
perhaps a pulmonologist.
yes,
Perhaps a cancer treatment center is
Yes.
involved. Tell us how UNC Nash's marriage to UNC helps us with that.
So we have the UNC cardiology here. So if you have a heart history, you need your cardiac cath or your assessment prior to a strenuous surgery, then we have you be seen by them prior to surgery. Let's say you have a cancer that's diagnosed, then you have UNC Oncology here, who are a part of our system. So you're exposed to all the different trials that are available right here at Rocky Mount, so you can get that treatment here.
And we'll talk more about that
Yeah.
after our break.
Yeah.
But so basically, is it true what you're saying is that we can tap into
Yes,
all the bigger systems that UNC is involved with,
yes,
so that we exploit all the research,
Yeah.
all the clinical trials, which means if there's a new medication that's proving effective in the world, that we have access to it locally,
exactly,
right? Because we're part of that same system.
exactly.
And people love to stay home when they're sick, don't they? The family
Exactly.
wants to be able to just go home at night right there and then come in the daytime and see them. And there's
Exactly.
just a lot of, I think it helps one's healing to feel comfortable in one's own hometown. And so for us to avail that same level of care right here
Yes.
is just a real blessing for our community.
Yes, absolutely.
Well, we're going to show the robotics video. We've got a
We
robotics.
will
before
in a
we
little
get-
bit. We're going to take a break now.
And then okay, I
We're-
really want to see it. I'm anxious.
Yes.
We do have, to give you some advance notice of what we're going to do. I'm going to go in a minute and cough in a second. But what we're going to do is we have a video, some photographs.
Yes.
And we're going to talk about gallbladder disease in a little bit. We're going to talk about breast cancer and breast surgery. We're going to talk about colon surgery and hernia surgery. As an introduction to that, we're also going to talk about our recovery systems and protocols at the hospital.
Yes.
In between that. So let's take a break and we'll see you folks in a little bit. And please call in. The telephone number is down below. Any question that you have, we'll take them.
That's her
and we'll answer
office
them.
number. I mean, people
Yeah.
can call her, but if they want to call in, I think it's, Lee, you want to put it up? I think it's 407-1111, 252-407-1111. So if you want to call in, or you can tell Lee and he'll come in and tell us if you would prefer not to be on air. Okay? Take a
Perfect.
break. We'll be right back.
See you in a few minutes.
Thank you.
This is Nicholas Bellamy at Premier Equipment. I'm going to talk about the 4540 Mahindra. It's 38 horsepower, full cylinder engine. The weight of this tractor is 4,000 pounds. This tractor is perfect for bush hogging, distance, small garden, a hunting club tractor. Comes with a 7-year warranty, 2-year bumper to bumper, additional 5-year on the powertrain. You can have this tractor for $200 a month, and we have 20 of these tractors in stock. Premier Equipment is open during the week from 8 to 5:30 and on the weekends from 8 to 12.
It's Christmas time in Selma, North Carolina, live at the Rudy. We're so excited to continue our 23-year tradition as we present the 2021 Christmas Jubilee. There's no better way to celebrate the Christmas season than to bring friends and family to Live at the Rudy's Christmas Jubilee. Kids under 12 are free, so how can you lose? Well, that's right, you can't. Make reservations now. Buy tickets online at rudytheater.com or call 1-877-THE-RUDY.
I'm Daniel Moss, owner of Cornerstone Funeral Home, and I'd like to invite you and your family to give our family an opportunity to serve you in your time of need. And we offer a full line of funeral services, everything from visitations to graveside services to cremations on site with a live crematory, as well as a banquet hall to meet the catering needs of our families that we serve. We offer catering service. We offer refreshments prior to visitations and services of our family, and we want to invite you to come and experience the difference here at Cornerstone Funeral Home.
Welcome back, everybody, for the second portion of today's show with Dr. Warrensby. And as promised, we're going to start talking about specific diseases, right? Let's say that somebody comes to the Nash ER, which is under new management relatively recently and infinitely more efficient.
It's Wake. I mean, we partner with Wake, WEPA. Isn't it WEPA?
Yes,
And they're wonderful.
Absolutely
I mean, the feedback
wonderful.
we're getting, and I'm glad as two physicians, because as a person in public, I hear it all the time. But I'm glad that y'all are seeing it as physicians there too.
Oh, we clearly do. And in fact, from an orthopedic point of view, I take care of almost all the hand injuries at the hospital. And I will get calls from these highly skilled people, and especially their PA team is wonderful. They're just amazing. This is a photograph of what I saw. This is what I did. Do you approve? And almost always they nail it perfectly. The level of care that's provided there, and for people to get triaged in and out and sent over to the office is perfect. That's from my perspective. From your perspective, if they come to an emergency room, they often need imaging studies like they do for me. And Nash's ER has modernized its emergency room facilities in that they expanded X-ray and CAT scan and MRI capabilities right attached to the emergency room.
Exactly.
So you can get in and get your emergency studies done immediately and not compete for the people who are inpatients and not compete for people who've scheduled outpatient MRIs. If you need an emergency study, you're going to get it. You're going to get it in a timely way. You're going to get it read perfectly, and you're going to get it read immediately by a radiologist. And then so they get this study, and then let's say you meet them there, and you determine that they need surgery. They're going to go to a modernized preoperative area that's currently being modernized and expanded. Right? To meet the increased demand for the wonderful services that people like you and your team are bringing on. Let's say they have gallbladder disease. Tell us the modern way that you're going to manage this gallbladder disease. Because that's a common way to
Yes.
come to an emergency room.
Very much so. It's one of the most common problems that people have. Over 20% of the population have some issue with gallstones or gallbladder disease. And if you could bring up a picture, I can kind of give you an idea where the gallbladder is located. Most people will notice this little green oval structure is up under the liver, and it's on your right side, up under your ribs. In that green structure called the gallbladder is where you develop gallstones, or you can have just dysfunction where it doesn't empty. The job of the gallbladder is to empty bile, that bitter stuff when you have the vomit. Its job is to help digest our wonderful North Carolina Southern food. And when it's not functioning well, you notice after you go to a restaurant and eat something, you get that pain. So you get an ultrasound, usually is the first study to get performed in the ED to look for gallstones. And if they find gallstones, then we can admit you to the hospital if it's an acute attack that requires surgery right then. If your pain gets better, then we can let you go home and you decide to do the surgery electively. We
Which
have
means as a scheduled thing.
an outpatient surgery, on a day you choose. We have a video of a gallbladder surgery being performed robotically.
But before you show that video,
Yes.
My first incision that I ever made on a human body was for a gallbladder.
Yeah.
And it was an accountant, and I felt so guilty about the length of my incision. I used them. He was a horrible accountant. I used them for 15 years, and I felt so bad because this incision was this big.
Oh, wow. That was an open gallbladder.
Oh, it was an open gallbladder.
Yes.
Because you had to be able to get your hands
Hands in there. Yeah.
You had to see it.
Yeah.
You had to be able
get
to
your
grab
hands
them.
in, feel it, see it. Yes.
Right. And then, after you made this large incision, then you put a tube inside.
Yes.
It drained out. You stayed admitted to the hospital for 5 days
Yes.
at least.
And your recovery was a couple of weeks, whereas laparoscopic, usually within a week, you're back to doing your
But you're
normal
home
thing.
when? But
You're
when?
home usually the next day. If you schedule it as an outpatient surgery, you're home that day after
day.
surgery, that same day, and you're home and you're eating and you're starting to move around and get up and walk, and within a week, usually you're back to eating your regular food.
Wow.
Yeah.
Yeah, I just remember when I was doing rounds as an intern, people throwing up for 5 days in the
Yes,
hospital.
Exactly.
And not eating normally for several weeks.
Yes.
Yeah.
Yes.
What a change.
So you're going to show us a robotic version of doing it?
Yes, and the reason why a lot of doctors do it robotically versus the laparoscopic is, one, the magnification, and two, is this wonderful system called Firefly that can turn your gallbladder green so we can see the anatomy a little bit better. We give a little dye before surgery.
It's a digital enhancement.
Yes, and so it's a medication that's in your bloodstream that the camera reflects off of, and it turns it green.
Well,
It's pretty
so it
cool.
looks just like the diagram.
Yes. It's pretty cool. You can pull up the video and I'll kind of talk you through. So the gallbladder, it looks yellow there. That's fatty tissue that we're dissecting off. And I'm looking for the tube that connects the gallbladder to the intestines. And that's when it turns green with that Firefly. And so I can see the anatomy a little bit better. And usually the surgery is about an hour long, an hour and a half. And afterwards you go to recovery. You get excellent care and recovery and pain management. And then you'll be discharged home. The great thing about getting it also done robotically is the minimal need for pain medication. With the national crisis with narcotic abuse, we want to minimize people exposure to narcotics, and that's one of our ways of doing that.
Oh, sure. The smaller the incisions, the
Yes.
better, the faster the recovery.
Yes.
I, for one, have rarely, if ever, refill a narcotic prescription, and I give half as many as I used to when before my endoscopic surgeries came out.
Right.
I do all my, for example, carpal tunnels through very small incisions.
Yeah.
In the hand, it's called endoscopic. In the belly, it's called laparoscopic.
Yes.
But it's the same thinking, and I've been doing endoscopic surgeries for 20 years, and I've never re-prescribed or refill for a narcotic.
Yeah.
You know, so and now that our procedural dictums from the state have told us that we can't give
Yes.
extra narcotics.
Exactly.
You don't have much of a choice as a
No.
patient because you're not going to get it.
Yes.
And so the smaller the incision, the more skill set that the surgeon has.
Yes.
So that you have a smaller incision and outpatient surgery, the less likely you'll need it in the first place. And that's
Exactly.
a wonderful thing.
Yes.
I want to ask a question about the robotic because you're talking about the magnification. So for people who've never seen robotic surgery,
Yes.
you're looking at a screen, right, and
Yeah.
performing it with there, and those little things we saw on the screen a minute ago are your hands taking the place of your hands.
Exactly.
Little bitty things, but you are actually not even, aren't looking in there obviously with the little incisions. Tell us what you're looking at and the size of it and how that helps you.
So what I'm looking at, I'm actually sitting at a console that almost has those little cameras like those 3D gaming consoles that you put on your eyes. You sit up there and you can see what the camera is showing me inside of your abdomen. My assistants in the room, they have a big TV screen. So when you think about the magnification, think about the original flat screen TV, how it was wonderful compared to the tube TV, and now the 4UK TV, how you can see the pores of an actor. That's how great the magnification difference is now, that I can see such tiny detail looking at this into these goggles. And then I have hand controls that are controlling everything that the instruments do. So I'm still in the room, I'm still involved, I put all the instruments in, and
Plus
then
the
I control
camera.
it. Yes.
And where is the camera located?
It's located, usually the incision is in your belly button, and it's a long cylinder-like tube that we slide in the camera, and it's in the belly. And it attaches to an actual machine, the robot, that holds it still. So it's not dependent on somebody, whether they have a shaky hand or if they're distracted by something, the camera goes in the wrong direction. I control all of the instruments.
So an image, for people who can't envision what this looks like,
Yes.
it's kind of like one of the Transformer movies.
Yeah.
Where a machine, it's a white machine with multiple arms,
Arms.
like the spider.
4 arms, yes.
4 arms.
Yes.
And those 4 arms are controlling instruments and a camera.
Yes.
That's inside your belly, but you're not standing over like the person like we're
Right.
used to. You're all to the side of the room,
Right,
sitting down at a console like you're playing a video game.
correct.
Really, but you're doing detailed surgery and you're looking into a monitor, seeing much greater detail than if you were actually standing over the patient.
Right. Greater detail than if I had my hand in the patient.
Right.
Yeah.
And working machinery that has the ability to manipulate much more precisely than your hands could.
Yes, and they can get in the small, tight places and have 360 movement that helps do the dissection and
And the risk of damage to tissues that are right next to them is way smaller.
yes,
An infection, you're not opening up big wounds for infection
Exactly.
or anything
yes.
too. Good, thank
Yeah.
you.
How does your skill set, because not everything you do is with robotics, and
Correct.
obviously if only 1 out of 5 or a little bit less of the surgeries done in the United States are done robotically, that means that you still lay your hands on other body parts that
Yes.
need surgery,
Yes.
because not everything lends itself
To
to robotic
robotics, yes.
surgery, right?
Yes.
So your skill set, and that of all surgeons, has to cover a wide breadth of procedures.
Yes.
Let's talk about breast cancer, for
Absolutely,
example.
yes.
Another very common thing. It's a very fearful cancer that people have.
Yes.
Or fear of that cancer.
Yes.
You know, my wife has a lump on her breast, and I'm concerned because it wasn't there, 2 menstrual cycles ago.
Right.
How do you approach that person?
Most patients who arrive to see me, usually they've had a mammogram or ultrasound performed at our Women's Center, where you can get all those studies done. And they found some abnormality, something different in their breast than the previous mammogram, or the patient has felt something different in her breast, or her husband has felt something different in her breast. And so once they arrive, we go over their ultrasound, their mammogram. I kind of explain the anatomy of the breast and how it functions, and then we decide how are we going to get a tissue sample to determine, is it cancer or is it not cancer?
Which is really the question that they have, correct?
Exactly.
And an ultrasound is a type of imaging study that doesn't stick any needles in you or anything. It's a little ultrasonic transducer that puts sound waves through the tissue that you're looking at, and depending on how those sound waves bounce off of it,
Right. It'll show us.
it'll show a structure such as a mass.
Right.
Because we know what normal tissue looks like.
Right.
And therefore we can define abnormal tissues that are things that aren't where they're supposed to be.
Exactly.
Right.
But our Women's Center also has a 3D capability too, which
Yes.
we haven't always had.
Right.
So it's really good for our community that we do have access to a
Yes.
3D mammography.
Yes.
So it can tell us the size of a
it.
lesion.
Yes. So usually a mammogram, the breast is
Squashed.
compressed, compressed from the top and bottom, and then kind of at an angle. And so you only get an two-dimensional study. Now they have a three-dimensional where they can take a series of pictures just in that same compression and kind of compose a 3D picture and look at the different densities in the breast tissue and get a better idea of the location, so it's less room for error.
And those types of studies are out of my area of expertise, obviously, but I'm sure it's the combination of those two studies, because
Yes.
they probably tell you different things, correct?
Exactly.
And so a combination of those two studies,
Yes.
when you have those in your hand, you can then sit down with a patient and make a plan.
Yes, and so we can decide what type of biopsy they would need, and where we would do it. Sometimes a patient prefers, even though we say, this is 95% likely that this is not a cancer, and they say, I want it out. Great. We can send them for an ultrasound guided biopsy, where they use the ultrasound again and then use a core needle, a needle that's hollowed out, that they can take a sample of the breast tissue and send it off and have it looked at under a microscope, and then we can tell them, this is what you have. Or there's also a mammogram guided biopsy, where you're in the mammogram and they take a core biopsy also of that tissue.
This is not done in the operating room.
No, this is done in the Women's Center, in the Women's Breast Center. Yes.
Tell us a little bit about the Women's Breast Center.
Well, it is located in the Nash Medical Mall, Nash Medical Arts Mall, and it's on the second floor, and it's where you can get your yearly screening mammogram, and you can get your ultrasounds.
All services, all state-of-the-art services in
right
one
there
place.
in one place. And it's great that my office is on the first floor from there, and so we get calls all the time from the radiologist saying, we think this is breast cancer. Can you get this patient in right away so that we can get them started on their treatment?
Can I ask you to backtrack a second? If somebody doesn't want to go under anesthesia again and get a formal incision and a biopsy, meaning they take a piece of tissue from the breast, you surgically take a piece of tissue. In the mammogram machine or within the ultrasound department, a radiologist can then take a piece of tissue.
Yes.
That's interventional radiology.
Yes,
Correct.
it's the radiologist, and we have some who are specialized and trained
And that's
breast.
the point I want to make.
Yes.
Is that we have a specialty team of radiologists whose subspecialty is taking those biopsies of tissues, and I use
Yes.
them all the time.
Yes.
And they're wonderful because they can help me get to places that I otherwise don't want to put a scalpel into.
Exactly.
The same way, with the same benefit that your robotics will help you do surgery through small incisions.
Right.
Our modern interventional radiology team can, through a CAT scan or an ultrasound,
Yes.
or a mammogram. I didn't know
Yeah.
this about mammograms
Yes.
before. You can actually put a needle into that suspected bad tissue,
Exactly.
take a piece of it, send it to our wonderful pathology department,
Yes.
and then get an answer without an incision.
Exactly.
That's wonderful.
Yeah, and then so for those women who have questionable mammograms or ultrasounds, they now have an answer, and then it's either, no, it's not cancer, you're fine, we'll continue on your yearly screening, or yes, it is cancer and this is the type. So now we can make the plan for what your surgery is going to be.
Okay, so you make a plan for surgery.
Yes.
And I think you have a photo of that for
Yes.
us, right?
Yes.
And while the photo is up, you can describe the photo that's about to come up when Lee puts it up. But then after that photo is on the screen, tell us about first the photograph, and then I want you to talk to us about how you coordinate with our state-of-the-art Danny Talbot Cancer Center.
Yes.
Because not only is it important that the problematic tissue be biopsied or removed,
Yes.
but that doesn't mean that the woman's comfort is suddenly enhanced. They're still worried that it spread someplace.
Exactly.
Right? And that's where you involve the cooperation
Yes.
with very talented people, state-of-the-art cancer
Yes.
treatment people that are right next door to you.
Yes. So this is a picture of the breast, and what we always think about is not only about the breast tissue, but also the lymph nodes or glands that are in your armpit, all the way tracking up towards your lower neck or your collarbone. Breast cancer, if it is diagnosed as breast cancer, can spread to those lymph nodes. I like to always kind of give a metaphor of the breast tissue, where you see the ducts and the glands. Those are like your neighborhoods and your cul-de-sac neighborhoods that are kind of isolated. And then there's a little back road that travels to those lymph nodes that we want to check and make sure no cancer cells have got on that road and gone to those lymph nodes.
On a previous show, we
Yeah.
with Dr. Train, who talked about vein disease, we actually talked about lymph nodes. And
Yeah.
but let's take a second and define them again. They're just filters,
Yes.
and they help take fluid out of tissues that leaks out of veins.
Yeah.
But God was smart, and He put a filtering system in this
Yes.
channel of tubes to catch any bad things.
Yes.
And so bad things include bacteria,
Bacteria, viruses,
viruses.
and cancer cells.
and cancer cells. So if
Yes.
we take a piece of that lymph node, it gives us a hint that's if there is cancer there, that it may have spread to a lymph node.
Correct.
Because if it's spread to a lymph node, it's on its way out of town.
Yes,
Right.
exactly. It's on its way out of town, and so we want to get the first lymph node that would have exposure to the cancer, and that would be called a sentinel node biopsy.
Is that the one closest to the mass?
It's not always the closest, it's just the first one that we have exposure. And so it's a very unique surgery of injecting a special dye in order to follow that pathway. So we inject on the breast and wait about 30 minutes, and it goes to the lymph node, and we have different kinds of probe that it's a little radiation probe, almost sounds like a metal detector that finds where that medication went to the lymph node, and it can tell us which one has the first exposure. And if those lymph nodes are negative, then we're pretty darn sure it hasn't gotten outside of the breast.
That's got to make somebody feel wonderfully comfortable.
Absolutely, yes.
Right?
So we know then the staging based on that.
But not every mass you see or take out, you're going to suspect cancer on, correct?
Correct.
So would you then, say somebody came back to you and they did not, and two questions, you did not suspect that it was cancer, it was just a fat ball or a fibrous tissue that in your vast experience and that of your team, you would say, hey, in my experience, this is very benign.
Right.
we don't have to go biopsy a lymph node.
Correct.
Then you just watch it.
Yeah.
And by watching it, do you do more than a CAT scans or mammograms or repeat ultrasounds?
We can also do, they have the breast MRIs here, so we can look a little bit closer at
A specialty
the tissue.
MRI.
A specialty MRI just for breast tissue. And we have a wonderfully trained a specialist radiologist who that's her thing, is to look at breast MRI and interpret.
So to that point then,
Yes.
the care doesn't stop there.
No.
The investigation doesn't stop.
No.
The comfort that you're imparting on the patient doesn't end,
No.
right? And so as they go older, they're carrying the fear with them that, oh my God, what if they miss something? Or, oh my God, what if it comes back?
Yes.
Or, oh my God, whatever. That fear never leaves somebody who's had a diagnosis of cancer.
Right.
And you're saying that our wonderful cancer treatment center can actually follow that patient.
Absolutely.
And they have a program in place
Yes.
to follow that patient.
Yes, so it's always a communication between the radiology team, where they send out notices to say, hey, every year it's time for your mammogram screening test, so you don't slip through the cracks there. They send a copy to the surgeon, your primary care doctor, as well as oncology. And then they have wonderful nurse navigators at the cancer center who check all the mammograms that have any abnormalities on them and make sure that that patient is being seen by the correct
I'm glad
medical
that-
oncology or radiation oncologist or the surgeon. Yeah.
I'm glad that you put the word wonderful and nursing in the same sentence.
Absolutely.
Because I firmly believe they run medicine.
Absolutely.
No doctor looks good unless it's at the expense and labor of a nurse, right?
Absolutely.
And
Right.
because of the increase in the number of cancer patients we're seeing there, they've
Yes.
hired more staff.
Yes.
I know they were talking recently about the time to third, which it means how fast they get them to somebody who can really give them a treatment plan.
Yes.
They're crunching that down as tightly as they can because they realize, Dr. Warrensby, just what you said, the anxiety
Yes.
of patients. So the hospital, Nash UNC, really wants to be sensitive to getting them that time to third, meaning get them to that appointment where
As soon
here's
as
the plan.
possible.
Time stops between when you've been biopsied and you hear from the doctor
Yes.
what your biopsy was.
Yes.
It is the longest 3 or 5 days
Yes.
that there could possibly be because you're just worried.
Yes.
Understandably.
Yes.
All three of us, if we got a biopsy, we would all worry.
Yes.
And that would be a long 3 or 5 days for us
Yes.
too. So to have a protocol in place to crunch that down
Yes.
just reflects the fact that we're taking care of a community.
Yes.
Right? We're not a big institution where the people that we're taking care of are not going to be our neighbors, and we're not going to rush to take care of them as if they are our neighbors. I think
Exactly.
that's a great approach.
I mention nothing to. We are part, by virtue of being part of UNC Lineberger, that's one of the 3 comprehensive cancer centers in the state of North Carolina, which
Absolutely.
is wonderful that our state has 3, Duke, Wake Forest, and UNC. But because our cancer center at Nash UNC is affiliated, it's an affiliate of UNC Lineberger, then we have that comprehensive cancer, just the strength and the resources
Yes.
of that institution right here in our community.
Yes.
You get the same exact care as you would get
Exactly.
if you were in Chapel Hill, Duke,
Yes.
or Wake Med.
Yes.
And
Yeah.
the research and the access. I know
Yes.
I've done volunteer work at Lineberger, and our physicians are respected internationally. I mean,
Yes.
they go to conferences all over the world
Yes.
and present their research, whether it's on gene therapy or immunotherapy, or, I mean, the research they're doing is at the top.
Yes.
And one of the advantages of an academic center like that is that they do protocols, and we join those protocols.
Yes.
And so meaningful data, we don't just benefit from that meaningful data, but we contribute to it.
Exactly.
We've got multiple clinical trials going right now at our hospital.
Right. That means the education we can provide to people is important, that
Exactly.
the protocols that are important. And it helps us recover.
Yes.
Talk to us a little bit about how we use protocols and patient education to help recovery. There's a name for a system that we have at the hospital
Yes.
for enhanced recovery.
Yes.
That has no system in the United States is better than this.
Yes. So
Teach us this.
enhanced recovery system.
What a segue.
I know, right? It's called ERAS is the nickname for it. And basically we use this as a way of, one, starting before surgery to get you prepared by making sure you're hydrated, and you've had enough fluids, you have enough nutrition in your body.
Your protein levels are up.
Exactly, your protein levels are up, so they recommend different protein drinks to take in prior to surgery. For example, a colon surgery. Everyone knows about the wonderful bowel prep you have to do before a colonoscopy. That can really drain you. And so this is to give you back that hydration that you lose. Then it's all about controlling your pain prior to surgery, preventing those pain fibers from being stimulated before you start.
Huge fan of that. Don't
Yes.
invite him to the party.
Exactly. So before surgery, you may have Tylenol that they give, simple pain reliever. Some other pain relievers, Lyrica is another one that helps keep the nerves from being stimulated. Then we have wonderful blocks that our anesthesiology department perform.
And by blocks, we're talking about injections of numbing medicine.
Yes. So basically they use long-acting numbing medication. You hear about lidocaine and Novocaine. These are more advanced numbing medications that last anywhere from 12 to even 36 hours after surgery, that they do injections along certain nerve endings to keep them quiet so your pain is a minimum. So they inject those. So we're looking at every way to prevent pain. And then we monitor you during your surgery, giving certain amount of fluids based on your weight, your heart condition, your lung conditions. We take into account of all of that. And then after surgery, we have a protocol of how soon after surgery you eat, how soon after you drink, even when do you get up and get out of the bed after surgery to start walking in the hallways to help stimulate your intestines, your lungs, your heart.
Prevent blood clots.
Prevent blood clots from happening. That's all encompassed in this protocol, that the orders are written for you, so I don't have to remember, did I miss something?
Right.
It's already there, and the nurses know what to do.
Protocols lower complications.
Yes.
They are procedurals that are designed by what we call medicine. Well, the phrase exists in other fields as well. It's called best practices. We learn from mistakes.
Yes.
We learn from ours, but not just ours. We learn from other people's mistakes, and that's critical.
Yes.
And that's the advantage of being part of a big system, is that your protocols, which are set up on best practices, are not just your experience.
Exactly.
It's thousands of doctors' experiences.
And it's
to make it right.
ERAS, that's the name for it.
ERAS, yes.
Okay,
And-
that's relatively new, isn't it?
Yes, it's probably in the last 3 to 5 years we've been pushing more towards it, and some surgeons and doctors have kind of picked at pieces that they wanted to implement because they were worried about how quickly things were being done and how to adjust for the particular patient you're dealing with. So you still can kind of customize it, and we still look at the patient's history and adjust it for that, but we have a basic protocol to help.
What pathologies does this protocol really work for? Perhaps not so much for for breast or gallbladder disease, because there are mostly outpatient surgeries.
Exactly.
It's really designed for people with more advanced colon problems,
Right.
and hernia type problems, correct?
Colons, hernias, GYN, or when they have a hysterectomy, they have a protocol also. So it's all encompassing now. Even urology, when you're going in for your prostate surgery or kidney surgery or bladder surgery, they also have protocols also.
Perfect.
Yeah.
Tell us a little bit about your the presentation of a patient who has colon issues.
Colon.
Say they fear colon cancer.
Yes.
Right. I sent off for that Cologuard test, and it
Yes.
comes back positive.
Yes.
Right. Doctor, help me.
Yes. So the Cologuard is a test for, where they look at your stool and see if there's any abnormal cells, anything that shouldn't be in your colon. That does not mean you have colon cancer. That just means some abnormal cells are there. And so the next thing would be is to get a colonoscopy. The colonoscopy is basically an endoscopic procedure where we use a long camera that's flexible, that has a fiber optic camera that we are able to look in your colon. Think of it like a long tube. We're looking at all the way around it, and we're looking for any polyps or anything that is abnormal present. The most common thing we've actually find on colonoscopies are diverticulosis, which is, people have heard about diverticulitis, and itis just means inflammation or infection. Diverticulosis is basically a pocket in your colon, and about 20 to 30% of the people over 40 have it. 50% of people over 60 have it, and most people over 80 have it. And it's basically bulging. Think of an old tire. When it's under pressure, it bulges. The wall of the colon bulges. And what makes the inflammation happen is usually bacteria gets in that wall and causes an infection. Diverticulitis is very common, and it's one of the few things that bring you into the emergency room along with your gallbladder.
Right.
And so it's very important to think about your colon health by staying regular as far as your bowel movements, your water intake, your fiber intake, and those all help with colon cancer also.
So say somebody does have a positive, and you do a colonoscopy, or one of the gastroenterologists at the Boyce Willis Clinic does, and they're wonderful there. And they do a colonoscopy, and they give you a call and say, listen, I did a colonoscopy, I'm going to send you over a photograph, and I see a polyp, which is just an abnormal piece of tissue that's growing on the inside of the colon.
Yes.
And I see this abnormal polyp, and I can't get it out through the colonoscope, because often you can take them out during the colonoscopy. But let's say this person could not, the doctor could not, and they give you a call.
Yes, and then I would see the patient, and we would talk about removing the colon.
A part of it.
Part of the colon, and that would be the section that had the polyp in it. And this is another procedure that we could perform robotically with the XI robot. Small incisions to remove the portion of the colon, but we talk about the different risks of the polyp, if left in place, turning into a more advanced cancer, which makes a more advanced procedure as far as when you have to remove that portion of the colon. So it's pretty exciting.
So do you just take kind of a punch portion of it? You don't take a whole slice of it out?
We take a whole section. So if it's a polyp, we take usually 2 centimeters before and 2 centimeters or 2.5 inches before and above the area.
And you just sew it back together all the way around?
Sew it back together.
Interesting.
And depending on the location, we also have to think about the blood supply to that area. If it's cancer, then we have to do a little more extensive surgery because of those lymph nodes, again, that we need to get to see if the cancer has left the colon and it's on its way to somewhere else.
Can the lymph nodes be biopsied robotically?
And certain surgeries, yes. It's very common with the prostate surgery when the urologists do it, that they dissect out lymph nodes that are believed to be involved in the cancer, and they're making sure that they're not involved.
That's wonderful.
We are getting near the end, and I know you always like to do your vaccine thing. Is there anything that, with Dr. Warrensby, that we want to jump on real quickly before you
Just
do that?
real quickly, not all, and I don't want everybody to think that everything to do with a bowel is cancer.
No.
It's not. 99% of the time, we're proving that it doesn't exist.
Exactly.
With both the mammograms, the ultrasounds, and that's what we are really about when we talk about biopsies. We go to bed happier at night knowing that we have 100% negative biopsies.
Exactly.
True statement?
Yes.
Right. But not all that we deal with the colon is cancer. Sometimes a little piece of colon sneaks through a hole in the body that wasn't there when you were born.
You get a hernia, exactly.
Right.
And so that's another common ailment, hernias. That's a bulge in your abdominal wall. Some people think about hernias, sports hernias, in your groin area, belly button hernias that you're born with, that
Hiatal hernias.
Hiatal hernias, yes. So basically, a hernia is a bulge or a hole in the abdominal wall or in an area where it shouldn't be. That some people have a hernia all their life, it never caused a problem. Bless you.
It's like one of those circus balloons that you blow up and the lid shows up in the wrong spot. But basically,
Yeah.
you can push the colon back through into that where it came from.
Yes,
If you get it in time and,
Yes.
and that piece doesn't die because it's choking,
yes,
and which happens most of the time.
yes.
You push it back in place and then you close the defect,
We
correct?
close the defect and we use a mesh. It's polypropylene. Most of the new meshes are lightweight. They're semi-dissolvable and they have a non-stick edge. That's what a lot of people worry about, is that something gets stuck to that mesh. But hernia surgery is very safe.
Perfect.
And a lot of people, the sooner people have it done, the better, because
Yes.
if they wait, like you said, I didn't realize that part of the colon could die.
Yes.
So check it early. Don't put it off.
No, do not put it off.
Yeah.
Yeah. So at the end of our show, we always talk a little bit about what the single most important thing in medicine in the entire world today is the COVID fiasco that's happening throughout the world. And I use the word fiasco and not pandemic for a reason, and that's because the pandemic is persisting, largely because of the fiasco of people not listening to facts. There are truisms out there, and there's baloney out there. And the baloney is pushed forward by many, many people. They could be our pastors, they can be other doctors, but there are truths, and I invite everybody to try to seek those truths by speaking to their physician.
Yes.
and trying to find out the true facts, because your life may depend on it, or the life of your loved one may depend on it, because you may be an anti-vaxxer, and I respect that. But if you get exposed to COVID and you survive that or carry that virus asymptomatically to someone you love, you can transmit it and cause their death.
Yes.
There are 16,000 cases today in North Carolina, 35 deaths in North Carolina, and it's a big deal. Please try to get vaccinated. If there's any questions that anybody has about vaccinations, my cell phone number is available to all my patients. You can call my office and get it. Lee, could you put up my email address again? It's goodbyehandpain@gmail.com. It's goofy, but patients remember it. Goodbyehandpain@gmail.com. Every single person that emails me and wants to get the straight truth on COVID, the absolute safety of the vaccine, and how it can save the life of your family and yourself, please feel free to contact me. I will get back to you personally on it.
And there's an uptick locally. I don't know if you saw in the paper, but in the latest data shows they're swinging up, and I guess it's the Omicron.
The Omicron is in virtually every state in the United States already, and the fact that it could spread so quickly is just a reflection of how we use the word virulent. It's how aggressively it spreads.
And if people are vaccinated, they're saying it's not that bad, but
Yes.
anybody who's not, it can be really bad.
It is going to be bad. So I invite anybody to email me. It'd be my pleasure and honor to help save your life and that of your family. Thank you again for joining us today, and we'll see you in a couple weeks.
And we're so glad you joined us too. Anybody
you.
who I hope everybody
job.
picked up here what a warm and wonderful personality you have too. So
Thank you.
We're glad to have you in our community.
And the
Thank
skill
you.
set of Dr. Warnsby and her partners is amazing. So please keep your business local.
Yes.
Wonderful physicians, wonderful facilities. Have a good week. Goodbye.
Goodbye.